at the volume of the drug, it is it determines the loading dose. We can use the volume of distribution of the drug to determine the loading dose of such drug, and of course, it is relative because it depends on the drug we're dealing with, and also the fact the patient factor also matters in the volume of the distribution of the drug, because it's not straightforward. And of course, based on demographic and data needed, age, disease conditions, gender, these are factors that will affect the volume of distribution of a drug. The volume of distribution is the hypothetical volume that relates drug serum concentration to the amount of drug in the body. And of course, the formula is the concentration or is equal to the dose over the volume, the volume of distribution is the dose divided by the concentration of the drug. The advantage the volume of distribution have is you can get your steady state with the loading dose at least as fast as possible. If you are able to identify the volume of distribution, this could help you to determine the loading dose that you needed to acquire the steady state. And this is very important in emergency because you don't have the time. But if you have the opportunity of knowing the steady state, and you also have the volume of distribution, all you need to do is to substitute, and you get to your you get a loading dose that will give you a therapeutic effect, and it will be safe for your patient. And at that point in time, you'll be able to have the action done. In case of emergency heart attack, in case of emergency asthma attack, all these cases, you can have your therapy done without stress. And we have the advantage and the use of this volume of distribution. There are drugs that have a very large volume of distribution and determines the potency of such drug in the use. Like digoxin, for example, has a very large volume of distribution of about 500 liters because it could attach to the tissues. Every tissue of the system, it could attach to every tissue of the body, and this makes it available everywhere and to be ready to work at every point in time. So this expands the volume of distribution, and because of this expanded volume of distribution, the drug is very potent. So you need more doses of this drug in order to elicit the effect, and they need monitoring too because of the potency. Another thing, warfarin, for example, has a lower volume of distribution of about 5 to 7 liters, and this is because it's attached to albumin, it's attached to protein, because the tenacity to protein particles is very high, and it's not always available to elicit effect at the receptor. So because of this, it has a very, very lower volume of distribution. So when you are considering this in the clinical context, so we look at the fact that because of this advantage, you still have to monitor it because it could lead to accumulation in the system. So the accumulation is not that why it attached to the protein. It's not that it's eliminated from the system. It's not that it could not detach. It's not that it could not act, but it's because it's reserved. And because of that, as a clinician, we must be wary of such, so that drug with such property of being able to have tenacity to the protein need to be monitored so as not to lead to accumulation and toxicity, as the case may be. So, and look at the body weight. Another area we should look at is the body weight of the patient. For people with for a footballer of 160 kg or a wrestler of 160 kg, it has a larger volume of distribution. And in that case, when you are administering your medication, you look at the because in the formulation or in development of drugs, there are a lot of factors that put into play. There are a lot of standards that put into play. There are other people who are overweight, and they are not really factor in a standard. And so when we are administering our drug, we might get feedback oh, I've been taking my antihypertensive for quite some time. I'm not getting response. And I've been taking probably amlodipine 10 milligrams. I've already reached the brief and I'm not getting response. And when you look at the weight, is not in consonant with the weight is like 170, 160. And when you are looking at somebody who presents with 50 kg to the hospital and taking the same dose, you know that you and I know that they are not the same. So the volume of distribution in an overweight patient is far, far more than that of ordinary person. But having said that, we still need to look at the whole thing holistically. We need to look at other factors, like the organs and other systems in order to make our judgment. But in terms of when we're talking about volume of distribution, we need to look at this critically before we make our judgments. And of course, we look at another pharmacokinetic parameter, which is half-life or elimination and elimination concept. The half-life of a drug is the time it takes to reduce the concentration of that drug from the plasma by half. And every drug have their own half-life. When you take your drug, the time it will absorb, and while it's absorbed, it continues to degenerate in the system, eliminated from the system, until when you get to half. And when you get to half, of course, so some drugs that are very potent, they have a longer half-life. We can take them in the morning and expect 24 hours work. The drug like amlodipine have more than 24 hours, more than 48 hours half-life. And of course, in this case, you can expect the drug to be in the system for quite some time. And half-life, most of the time, is used to, clinically, is used to determine the dosage interval of a particular drug. And when you determine the dosage interval of a particular drug as a result of the half-life, it gives you room to reduce toxicity, to also have maximum benefit from the use of the drug. These days in the clinical setup, we do have a situation whereby people take antibiotics, and for example, amoxicillin, they will give 1 gram BD or 1 gram BD. You look at the prescription and you ask them why. Because when you look at the half-life of amoxicillin, it's just 1 hour. So you ask, why did you give 1 gram BD? And this is very popular. And we begin to ask questions, why this is so. But when you look at it critically, you will discover that this does not stand the test of time. Because you look at the minimum effective concentration, and you also look at the maximum effective concentration. You also look at the toxicity of this drug. These are what guides us in order not to fall into problem when we are administering drugs. But the moment you administer 1 gram of amoxicillin, in the next 1 hour, the drug is going to be reduced by half in the system. And on it does. Like, for the next 12 hours, since you have given the drug BD, for the next 12 hours, you are likely to have a suboptimal dose of that drug in the system. And that will negate the treatment we are actually doing for that patient. So when in our practice, we look at this and let us be able to advise people, most especially when this kind of prescription, when this kind of things come up. Because in treatment of bacteria or in administration of antibiotics, we need to be very careful so as not to fall below minimum inhibitory concentration, and this will endanger the patient and also cause a lot of resistance to the bacteria. Because I've spent my time, I want to stop here. Thank you very much for the opportunity.